Like to like to welcome all of you here today to participate in this briefing on Kratom. I'm proud to have you here. I served in this place for 10 years myself. I was a member of the House representing the great state of Arizona for 10 years. As a matter of fact, that's when I first got introduced to Kratom. You'll hear me say Kratom. Everybody does that, right, Mac? Switches back and forth. But I think I first learned about Kratom back in about 2014. And I've got to tell you, back then, I believed that it was something that could strongly contribute to the health issues that we face in this nation. But in 2016, when the FDA was contemplating scheduling Kratom, I was able to spearhead an effort to send a letter to the FDA with people on both sides of the aisle, both from the House and the Senate. And we were able to get them to rethink their position. And I'm really thankful that once they actually relied on science rather than emotion, they've never reconsidered trying to schedule it again. But the fact is that there's a lot of information out there, and I will say this point blank, most of it is misinformation. I had knee surgery, I had knee replacement about 3 years ago, and I personally used Kratom rather than opioids. And I used it for about a month after my surgery and didn't have a lick of trouble not using it anymore, and I haven't used it on a regular basis since then. But the fact is, when you're making decisions that impact people's lives, like is done here in Washington, D.C. every day, you really should be doing it based on science. How many times did we hear that during the problems with COVID? Everything should be based on science. Well, everything should be based on science when it comes to things like Kratom as well. So I'm really, really appreciative for those congressional staffers, both House and Senate staffers that are here today to learn more, because today you're gonna hear the science, and that's a good thing. So I welcome you and I thank you for coming.
Good morning, everyone. It's a pleasure to be here. And actually, I love that concept about policies should be based on science. And when I was first starting to do research, that of course there was no questioning about it. And then I came to NIDA and I realized that science is not necessarily sufficient or enough to guide policy. So my perspective on all of this is how can we work together so that the knowledge that we have can be used ultimately for policy. Unfortunately, we don't know much about Kratom. We know certain things, and you're going to be hearing about it, and that is actually can guide many of the recommendations. But what we do know is that we are living in the United States the worst overdose epidemic that we have ever had. We're seeing a significant increase in suicide, and we're seeing the struggles that patients with pain have to deal on a daily basis. And the truth is that we don't have sufficient strategies to help all of these people that are suffering. How bad it is? Well, for 2022, the numbers, the preliminary numbers at least show that more than 110,000 Americans died from overdoses, just overdoses themselves. And we also know that patients that are struggling with depression and are also struggling with severe pain are also dying from suicide. And it's in this context that we need to understand and to hear the voices of people that are telling us their stories, sharing them with us regarding how Kratom has been useful for them, as we have just learned. So what do we know? We do know that Kratom is a plant, and as you have been hearing it, similar to the coffee plant. It is a traditional medicine used for centuries in Southeast Asia. It's basically taken by the oral route as either dry kratom, leaf power teas, foods, or beverages or leaf power filled capsules. We know that there is a market that is increasing with no regulations, with increasingly more powerful extracts. From the perspective of my pharmacology and understanding about why people are using kratom, We know that there's specifically the main active ingredient is mitragynine. And the mitragynine gets metabolized when you take it by the oral route to a certain extent into a metabolite, 7-hydroxymitragynine, that is also believed to play a role. But we also come to recognize, and the slides did not show it. Let me see. No, the slide disappeared. So you are getting the right one. You're going to be seeing the slides disappear. We know that there are 40 chemicals that in the Kratom plant that are likely to have to underlie why the products that people take vary depending on where they get it. We know, and a lot of from the work from mitragynine, as I say, most of the work has been targeting mitragynine and 7-hydroxymitragynine. We know that mitragynine, but much more 7-hydroxymitragynine, binds to mu-opioid receptors. And opioid receptors are the ones that are basically activated by heroin and fentanyl. But it does it at a much lower potency. And actually, we use medications that target these receptors to treat opioid use disorder, most notably buprenorphine. And we can use it because it has low potency in activating that receptor, but it does control craving and withdrawal. Well, we now know that mitragynine is much less potent than buprenorphine. And 7-hydroxymitragynine is slightly more potent, but it's much less than what we know about. And we also know that it binds to many other receptors that are likely to be relevant in its pharmacological effects. And this also may explain what people are telling us and what the laboratory experiments are saying to us, that low doses seems to produce stimulatory effects, presumably by activating receptors that are stimulating and not necessarily the opioid receptor, but high doses actually are sedative, and that may reflect, in fact, that very low opioid receptor effects that it has. We also know, and because we've all been following the data, that people that die from overdoses, a small percentage of them had kratom in their bodies. And we also know that in even a much smaller number of them, kratom was the only substance. And that number is very small. I want to reiterate. Now, when someone dies from a kratom overdose, which is important to understanding its effects, we don't have the mechanisms that kills people from opioids. When you take an opioid at high dose, you stop breathing. When you take kratom, you don't stop breathing. And in the instances where there's been fatality, it's associated with its cardiac effects. It's a stimulant, and in people that have the vulnerability, it can produce arrhythmias. We also know that when people in animal models, in fact, we can use mitragynine to block the rewarding effects of heroin, and we can use it to also, interestingly, block some of the effects of opioids, which tells us that this drug is interacting with a receptor in a very different way from the classical ones. And as I said earlier, kratom contains more than 40 alkaloids, and we're promoting research right now to investigate them further to go beyond just mitragynine and 7-hydroxymitragynine. What is the prevalence of kratom use in the United States? I wish I would know. And I was looking at the literature, and I got very disparate numbers, from 2 million to 5 million to even more. So the bottom line is we do not have good data indicating of actually what is the prevalence rates of kratom. And we've been discussing with our partners in other agencies to try to include questions that address the use of kratom as part of the annual screening that we do across the United States. Also, investigators have published data that actually looks at people who have been taking kratom and reported that tend to have greater severity of use of other substances, which actually in a way follows the narrative that we hear here for why some people are using these drugs to basically control their addictions. And we heard one from an opioid, a person that was addicted to opioids. So it is one of the reasons why people take kratom, apart from pain, as you saw, but it's also used for alleviating depression. And there are many areas that seem to indicate that kratom, when we compare it with other opioid agonists, is much, much less potent, and that highlighting its pharmacological effects are likely to relate to its mixed pharmacology. Can one become addicted to kratom? And this is an important consideration, of course. And we know, and there's been published papers that indicate that there is a kratom use disorder, which is the new terminology that we use to say kratom addiction, or cocaine addiction, we use cocaine use disorder, and so on. Now, the classification of a kratom use disorder, like other substance use disorders, have a severity from very mild to very severe. And what the data indicates is that people that are regularly using kratom can fit criteria for a kratom use disorder, but it tends to be mild or moderate. In very few cases, there's evidence of severe kratom use disorder, and those actually respond to buprenorphine treatment. So we, again, highlighting like what, in general, that overall at an individual level, we don't seem to see much pathology. But when you start to look at the population level, where the numbers become very large, then you start to document that it can produce addiction to kratom, and that it can produce overdoses and death. So what do we know about kratom-involved overdoses and death? We know that it is possible. In 2017, the FDA reported at least 44 deaths in association with kratom use. But most of those deaths also have many other substances on board, very likely the cause of why the person died. And in fact, if you look at also from that same data, 0.56% of people who died of accidental drug overdoses were for kratom. So it's a small percentage, and of that small percentage, the majority of them, specifically for this study, 87% had or involved other polysubstances. And the other element is, for those that didn't involve other polysubstances, there were contaminants and extremely high doses of mitragynine and 7-hydroxymitragynine. With this in notion, we say, well, how do we need to evaluate? Because it's always benefits risk. So the risk of overdosing is very low, and certainly nothing compared with what we are seeing currently in our country. But are there other ill effects? And as I say, and I really apologize because I don't know why the figures are not showing up, but what it indicated is what are some of the negative health effects that have been reported in certain people. And again, in general, it tends to be much higher doses or drug combinations or people that have vulnerability. So what do people die when they take kratom alone? I say arrhythmias, seizures, and liver failure. And again, I want to emphasize these are rare occurrences, but they do happen. And so research to investigate what factors can allow us to predict who is at risk and how to actually protect them is crucial. So in the last two slides, just from the perspective of health and safety, again, very low evidence that the use of kratom produces respiratory depression. But there are many things that we do not know that are important. We don't know how kratom products that are being sold with various contaminants influences health. We do not know much about that drug interaction. So you are in a medication and you're taking kratom. It becomes important to see that these drugs don't counteract one another or enhance one another. We don't have data on the long-term effects of kratom. And we also don't have data on the effects of the use of kratom during pregnancy. And again, the safety effects, when someone is intoxicated under kratom, are there safety considerations? So as I started my presentation, we have limited information. Why? Well, most of the data that we have is self-observation or reports, which are valuable, but actually not sufficient. We also know that most of the individuals taking kratom may be taking other drugs, so it is difficult to disentangle the effects of kratom from these other substances. What makes it hard? Several things make it hard. We don't have sufficient availability of kratom products for research purposes, or the content, the active ingredients. And also, we don't have right now an FDA-approved a constituent of Kratom for clinical trials, approved to actually go forward for clinical trials. As a result, we do not have studies that have evaluated the therapeutic potential that mitragynine may have for the treatment of pain, for the treatment of addiction, for the treatment of depression, or other conditions. So what is it that we're doing? This just identify some of the areas that we are right now funding to try to advance the science. I want to sort of state that one of the key things that we have invested significant resources is into the synthesis of a mitragynine product that will allow us to actually do the randomized clinical trials to clarify what may be the potential benefits of Kratom. Again, not just for pain treatment, for also for the treatment of drug addiction. We actually are very much open and recognize that one of the problems that we are facing right now in terms of mitragynine or 7-hydroxymitragynine is we don't know sufficient. We know people are taking it, reporting beneficial effects, but actually there's no oversight. There's no way of quantifying how to properly see the value. And with that, I want to thank you for your attention. And I don't know who's the second speaker. Are you, Jack?
So these are my, let's see, where I live and work. And let's see, do I just hit anything to get to the next? Okay, by disclosure, I provide scientific and regulatory consulting on medications development. That's mainly what I do. That includes abuse potential assessments, 8-factor analyses, drug scheduling nationally, internationally. We work in psychedelics, cannabinoids, and so forth. My opinions are my own. I also provide advising on science and regulatory policy to the American Kratom Association. I've been researching addictive substances for half a century plus. The first drug that I worked on at NIDA in 1980 was buprenorphine, and I'm really proud of buprenorphine and naltrexone, which we also contributed to, and most of the other treatments for addiction. But they don't, for a lot of people, they don't reach them, they're not acceptable, they're not effective, or maybe they are at one stage and then not a later stage. So that's part of the reason that I support access. I don't promote anybody using Kratom per se. I support access that is ideally regulated and more research. It's an honor and a pleasure to follow Dr. Volkow. She's a hero to many of us in addiction research and policy, and a real pioneer before she got to NIDA. But when people ask me about about Kratom science, I say, go to NIDA's website. That's a starting point. And so you'll see more than a little bit of overlap between what I'll be saying and Dr. Volkow, and I'll try to minimize that. But there's a lot that we don't know, as Dr. Volkow mentioned. And some people say, well, if we don't know much, how can we regulate? Well, regulation always starts before you know everything, and drugs are approved before you know everything. We do know a lot, but again, it sounds contradictory. There's a lot we do know, but a lot we don't know. More than 450 published articles in just the last 5 years. It's hard to keep up with it. A lot of it's thanks to NIDA's efforts. But there's also research around the world in Southeast Asia where they've been studying it for decades. And there's also now more research by some of you who are working on new dietarian treatment, new dietary notifications to the FDA, pharmaceutical development based on kratom-derived substances, and that's also increasing the research pipeline. Dr. Huestis will mention some of that. A good starting point, again, is the NIDA Drug Facts website. And Dr. Volkow already covered a lot of this. And I think the wording on the NIDA website is very careful, considered, conservative, if you will. But I think that's a starting point for the science. Something that was interesting to me when I first started looking at Kratom more than 10 years ago was I thought, okay, why aren't people injecting it? I mean, it's easy to extract 7-hydroxymetrogene. With most drugs that are widely abused, a lot of people like to heighten the euphoria. And very quickly, we're learning that's not mainly why people use Kratom. I mean, at Johns Hopkins, we also did injection studies with nicotine and caffeine and thought, oh my goodness, you can do this, it's easy. But that's not how people want those substances. Everything in safety and abuse potential, for that matter, is a relative comparative process. So oftentimes people talk in absolutes. Well, there was a Kratom death and one death is too many or whatever. And it is. We want to minimize any risks. But in drug development, it's always also relevant compared to what else is out there. So these are just looking at FDA's safety adverse events warning surveillance system, just comparing caffeine and metrogenine to one opioid, oxycodone. The orange bars are oxycodone in different years. And the little tiny flat bars, which you can hardly even see, are caffeine and metrogenine. It's a relative process, and that's important to keep in mind when you're thinking about public health and harm reduction. And Dr. Volkow touched on that as well. Again, as you'll hear Kratom referred to as an opioid. And 10 years ago, a lot of Kratom researchers were saying, well, it's an atypical natural opioid. Well, it's not an opioid by nature, law, or chemical structure, but it does have some opioid effects that are important. If it was actually an opioid, we wouldn't be here because it would be listed in the Controlled Substances Act. Respiratory effects, Dr. Volkow mentioned this as well. And Dr. Huestis and I and a few others did a study based on the FDA recommended protocol, which compares the target substance or combinations with oxycodone. And so our goal was to push the metrogenine dose as high as was physically possible or until death. And we got up to 400 milligrams per kilogram, and that was as high as we could actually get into the animals. And basically on the green side, that's oxycodone. The top bar, that's the therapeutic dose equivalent in a rat. No respiratory depression. It's pretty safe for all practical purposes. But at the higher doses, Death Valley plummeting respiratory blood oxygen levels and deaths in both of those groups. In the metrogenine dose group, there is no dose effect. This was amazing. No, it's flat. It jumps around a little bit. But we did not see respiratory depression and no deaths or life-threatening effects. At the highest dose, some grogginess in the animals, which lasted a couple of hours. 10 earlier studies, and our study was not novel, we just followed the FDA model and pushed the dose higher than most people did. But this has been looked at in multiple species and other studies. Dr. Volkow touched on the abuse potential, and these are rats pressing levers to self-inject morphine, which they do, metrogenine, which they don't. And if the animals were pressing the lever for morphine or in another study, heroin, and you gave them metrogenine, just like people in the real world report, it reduced the rewarding effects and they didn't take it. It blocked it. But 7-hydroxy at astronomical doses compared to what humans take can serve as a reward. And this is part of the reason we need regulation like FDA regulation to say, what is the maximum allowable level of 7-hydroxy? We need standards. 11 states are starting to do that. There's a myth that, well, if Kratom can relieve opioid withdrawal, it must be an opioid. But again, Dr. Volkow touched on this too. Clonidine has been used for decades to relieve withdrawal, opioid withdrawal. It's an alpha adrenergic acting drug used for high blood pressure. And lofexidine was actually approved in 2018 for that same purpose. It's not magic. How can this be that Kratom can have some opioid effects and not affect respiratory function and not have some of the other effects? Well, it's like trains being on different tracks that go through a station. And this is a NIDA supported study, and this is on NIDA's website, or was. And basically, the pathway, if you will, for mitragynine does not recruit beta-arrestin like opioids do. And so it bypasses that way station that causes the plummeting respiratory depression. So it's not magic, it's just pharmacology. International Commission on Drugs considered kratom for potential international scheduling, and they rejected it. And it was largely based on NIDA and other supported study. Also, they considered what they consider the therapeutic effects, and that's that in the US, therapeutic effects are defined by FDA since the 80s as FDA approval of the drug. Internationally, it's more loose. It's are people actually using it in the real world, like for traditional medicine? So they rejected scheduling. Last issue I'm going to touch on, and Dr. Volkow also touched on this. Some people say, well, extracts are bad, or extracts aren't bad. That's like saying I'm drinking coffee. That's an extract. But maybe something that was 10 times stronger shouldn't be. Soft drinks are, there's some oversight. The question is, what is the level? And I think this is part of where I would love to see FDA actively involved, because FDA is the best organization in the world to set standards for how much and how do you test it. So 11 states are starting it, but FDA could bring a lot to the table in a considered rulemaking type of process, including what should the warning label be? What should the wording of warnings be? When we address this with nicotine gum, we didn't say don't use during pregnancy for women that were smoking, because they would go back to smoking. The labeling said talk to your health professional. Again, that's a nuance. I'm not saying that's what should be for kratom. The point is, FDA tries to get the warnings science-based and not overwarn and scare people who could benefit from the drug. Warnings are not simple. You don't just put everything that might happen on a label and scare people unnecessarily. So, and in the context of the opioid and other drug epidemic, important thing to keep in mind, the drug epidemic is not just opioids, it's stimulants. Stimulant deaths are increasing. Kratom, the surveys in the US and Southeast Asia are showing, is being used by a lot of people to get off alcohol and stimulants. So we have something that looks like a more broad harm reduction tool than just opioids. And finally, I testified at one FDA NIDA hearing that was premised on we need more treatments to help those that are not helped by buprenorphine. And several speakers commented on kratom. And I said that for people who find kratom to be a lifeline away from an addictive drug, we shouldn't take it away. That would be like taking away a life preserver from somebody that's struggling in the ocean because it's not Coast Guard approved. You just don't do that. But you try to set standards. So in conclusions, you've already heard most of this from Dr. Volkow, but let me finish with the last one. Although many states are beginning to regulate kratom or consider kratom regulation, we really need FDA regulation at the national level, because they can set national standards. They know how to do labeling. They know how to get the warnings right. And they know how to set standards. What should the level of 7-hydroxy be? At this point, we're saying less than 1 or 2%. Well, maybe it's 0.5, maybe it's 0.8. What is the right test? We need FDA. Thank you.
So just real quick, who in here has heard of kratom like 5 years ago? Did anyone in this room? Okay, so maybe you're all just advocates and we're here just talking to ourselves. No, so I'm going to start my clock, and I am very grateful to be here today and talk about kratom use clinical trends in the United States. Disclosures, I am an assistant professor at Johns Hopkins. I came there by way of NIDA's intramural research programs through the National Institute on Drug Abuse, where I'm very thankful I had a wonderful postdoc experience. I have served as a paid scientific advisor to the International Plant and Herbal Alliance and the Kratom Coalition. I want to be very clear that the views that I express today are my own. I do not speak for Johns Hopkins School of Medicine, even though I do work there. So what is Kratom? Dr. Volkow has given my talk for me, so I will just keep this very simple. And I do want to highlight something that may not get brought up unless I flag it, which is that we see these beautiful pictures of these leaves, these green leaves, right? That is what's been used in Southeast Asia, Malaysia, Thailand for a very long time. That is not what is used in the United States. So when you see the stock photos of that, that is really not what Kratom in the United States is. And I think it's really important to make that distinction. The complexity of Kratom has already been discussed. Dozens of alkaloids just in the leaves. And those fresh leaves that are used in Asia are not what we're using here. You see this rainbow of different products that have proliferated, again, with varying concentrations and without any regulation, which is why we're here today. And so I think to understand, if you don't know anything else about Kratom and you leave here today, when we say Kratom, we are talking about dozens of things. And it's very difficult to study real world Kratom use because, again, the measurements differ and the products differ. And so we do have a lot of work ahead of us to understand this. So please understand that variability. And again, my colleagues and myself have written recently about this. You know, the marketplace has been called the Wild West. And I think that that's an apt characterization because we really do not have FDA or the industry or scientists really coming together in a coordinated effort to try to move forward clarity and science and also some common sense, you know, legislation. And I think that headlines like this, media stories calling attention to the marketplace are going to increase in the coming years. So when did this show up in the US? About 2007. So likely people were using it before then. However, we really did not have any clinical footprint of this until 2007 among chronic pain patients, people on opioids using for pain and then trying to either attenuate opioid withdrawal or substitute opioids. Since then, and as Dr. Volkow touched on, and really, you know, we have all-time multiple epidemics. So suicide, again, all-time high this past year. The drug, polydrug epidemic, not just opioids, but stimulants, alcohol, raging, along with chronic pain and psychiatric distress. And so our treatment systems are beyond maxed. They've been beyond maxed. And even though we do have evidence-based treatments for some things like opioid use disorder, not everybody has equal access to those. And I believe it is not a coincidence that Kratom did emerge in the United States as a lot of different prescribing guidelines were changing and as these epidemics were reaching, you know, a climax, which were exacerbated during the COVID-19 pandemic. So I don't think, and a self-report that has been NIDA funded, data have supported this idea that people turned to this weird plant from another country, you know, because they were desperate. And I came to know about Kratom in 2015. I was doing an addiction or a clinical practicum in an addiction treatment setting. I had a client who came to me and he had been on Oxycontin. This is in central Kentucky, and he had about 6 months sober. And he said, you know, I've started using this thing called Kratom. And I'm like, what on earth are you talking about? And I thought it was a synthetic drug. And he was like, no, 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 it's a plant. And it helps me with my craving for opioids. And my anxiety is decreased and I feel good, but I don't feel high. I'm like, who cares? Like, this is kind of boring. And I've said this before. I'm like, it's in some ways kind of boring. And I honestly did not realize the clinical significance of what this young man had told me. However, in my many years of volunteer work in Kentucky, continue to meet other people who were in early recovery or trying to get into recovery and who had turned to Kratom, many of whom, and I can verify this as firsthand, I've known they take Kratom daily, but they are not using the substances that they were addicted to anymore. I'm not making a causal claim. I'm not saying Kratom saved their lives. I have no idea. All I know is that they believe that it was helpful for them in their recovery journey. And again, we need more controlled studies to substantiate this. But right now, I do think we have a lot of self-report that is converging towards the same end. And so who now in 2023, who is using and why? We know most people are in their mid to late 30s on average, a really even split between males and females, vast majority non-Hispanic white, at least a high school degree, almost exclusively in some very advanced degrees. So we have a very wide range of socioeconomic status here, including income, education. Some have been using, maybe just started a month ago, but in our NIDA-funded work, you know, we have had people using it 16 years. So there are people on, I would say most Kratom consumers in the United States have been using for many years, those who are regular consumers. And of course, this is America. So if you're using one thing, you are using another thing, right? whether it's over-the-counter substances or prescriptions, which again could be very potentially dangerous, antidepressants, antipsychotics. In some recent work that we did, actually, I should say that among consumers using whole plant products, we actually didn't see a lot of illicit drug use contemporaneous to kratom use. Now, that doesn't mean there aren't these people doing that, because there are clearly, and we do have these fatalities associated with that polydrug exposure. But in our sample, it was actually a little bit boring in terms of what people were taking, and those data will be coming out in the near term. And again, among people who are using, most are using whole plant products. Some are absolutely using extracts, and I know it's a big part of the market, but I have studied mostly people using a whole plant material, and they're taking it 2 to 3 times per day on average. We've heard about harm reduction. So all of these here, which again, I've presented publicly, what you see are dozens of motivations for use. And what I want to draw your attention to, we've talked about, opioid withdrawal, attenuation, things like that. A lot of people are also using just to kind of improve their quality of life, improve their mood. And really, I don't think kratom gets enough attention for the stimulatory effects that it produces, right? So as has been discussed, we have people using for analgesia, but to the person, and I have talked to people at length, it is this combination stimulatory effect. People are taking this to try to be productive, increase energy, improve stamina, do triathlons. I kid you not, get on the Peloton and ride their bike. So this is not something that is, I want to take this and nod out, for lack of a better word. This is a very complicated, kind of weird plant, and people are reporting using it for many reasons. And you see this here. So these are like, again, I'm not showing a lot of data because they are not published. So I just want to kind of give a nod to the fact that we are increasingly aware of these proximal or immediate drivers of use. And really, it comes down to a lot of pain relief. But again, mood improvement, increasing energy, productivity, focus, alertness, feeling good, but not necessarily wanting to feel high, which we also evaluated for. So when I was at NIDA's intramural research program, we did have people come in who were chronic consumers of kratom, who'd been using it for many different years. And I'm not going to unpack all that because it would take me 2 hours, but I do want to touch on impairment because I don't know if anyone else will. And at least among people who are using whole leaf products regularly, we looked at psychomotor performance, cognitive performance. We did validated driving simulations. Those data are under review. I will just say that we did not observe any adverse effects, nor intoxicating self-reported effects, nor objectively evaluated impairing effects. Now, if you get some average Joe off the street and you bring him in and you give him kratom, I don't know what we could say about that. There could be intoxicating effects, but at least among chronic consumers, we did not see it, nor did we see respiratory depression, pulse oxygen changes, anything like that. And again, these data will be coming out very, very, very soon, within the week, hopefully. So what I'm best qualified to talk about is physical dependence and addiction. And Dr. Volkow touched on this, as did Dr. Henningfield. I've done with my colleagues at NIDA and other institutions 2 systematic reviews on kratom, physical dependence, abuse, misuse, addiction. The terms are all over the place. And there were 55 cases globally that we could include into that study, 40 different papers, 55 individual cases. That is a very, very small number. I cannot stress to you how small that is. Now, do I honestly think that is how many people are actually having some sort of physical dependence, like withdrawal or substance use disorder or addiction with kratom? No, I think it's far higher than that. But my point that I want to make is that the clinical impression that is being made, at least with respect to the published medical literature, is that this is not public health threat number one. I am not minimizing anything at all, but I'm saying that when I go to the American Society for Addiction Medicine conference and I talk to clinicians, I'm not getting the strong signal that this is the biggest problem they're facing. But I do think, as has been said before, we have very, very incomplete information. And I really want to stress that part. When we have assessed for substance use disorder for kratom or kratom use disorder, we don't see high rates of it, but it's not zero, right? And again, there are different symptoms that make up this diagnosis. And I think that's important. So again, mostly mild to moderate, both in this small study and then another study conducted by a colleague at Johns Hopkins, Albert Garcia Romeo. And that study is a few years old now. I think if we were to re-survey people or reassess people, we might see slightly higher rates just because people have been using for longer at this point. So again, not a lot of information, but again, the data that I am aware of, some of which is still under review, we do not have a lot of severity here. I want to also note that not all kratom substance use disorders are equal. So what we have seen signals of are what's defined as physical dependence. So there's tolerance, needing to take more of something to get the same effect, or withdrawal. And we do see craving. We do see some unsuccessful quit attempts. What we don't see in any of the work thus far are psychosocial impairments in daily functioning, giving up important activities, hazardous use, which to me are the hallmarks of addiction and are clinically much more disturbing. I'm not minimizing physical dependence, but again, we have to be really clear about which is which. And with that, I'll just say that again, most kratom withdrawal is mild to moderate. Takeaways, kratom has a strong foothold as a harm reduction tool and is in the chronic pain and recovery communities at this point quite strongly. There has been an uptick in use for all of these other things that have nothing to do with having an addiction. People are using it for, focus, recreational use, for energy predominantly. It is fairly regimented among people using whole leaf products, and we do have tolerance and withdrawal signals. And really, to the person, most people who use kratom regularly do believe that it is more of a benefit rather than a hindrance to their daily living. Again, the warning, there's a proliferation of new products, and we really, 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 really need to have some regulation around this, given the fact that we don't know what are in any of these products. And lastly, significantly more investment needs to be made in funding, both give money to NIDA, please give more money to NIDA, and then NIDA can hopefully give money to me. So at the end of the day, give money to NIDA, NIDA give money to me. And that's my spiel. So thank you very much, everybody.
Good morning. I probably have the most controversial talk, but I think it's really important. We're going to talk about adverse events and especially the huge number of articles coming out, lawsuits, et cetera, about the toxicity of kratom or metragine. We've talked about the pharmacology and how complex it is. The key big difference is that the kratom or metragine, the primary active compound, at least at this point, we think it's the primary active compound in kratom, is that it does not produce respiratory depression, or at least much less, because it doesn't recruit the beta arrestin pathway. That's the pathway that produces the respiratory depression and produces so many of the overdose deaths that we're faced with today. But it has a very rich pharmacology that includes many other receptors that I've listed up here. And the 7-hydroxymetragine is the metabolite that is more active at the mu opioid receptor than the parent metragine itself. But it is not present in fresh kratom leaves. The 7-hydroxy metragine that you measure is primarily from the metabolism of the parent itself. And we have almost coming out, hopefully, new data from humans with multiple doses of kratom, where we've measured both the metragine and the 7-hydroxy to provide some of the most important data for interpreting these concentrations that are coming up in these different postmortem cases. Now, the first evidence that came out about potential toxicity from kratom came out of Sweden, and they had 9 deaths that were called kratom overdose deaths. And my colleague, who's a good friend, Robert Kronstrand, at the National Board of Forensic Medicine in Sweden, they investigated these cases, and they found out that they had been adulterated. So they added O-desmethyl tramadol, which is a very potent compound with respiratory depressant effects. And they determined that all of the 9 deaths had high concentrations due to this adulteration of kratom. Another big reason, as all of us have been talking about, the need for regulation to prevent individuals from either adding very potent opioid type compounds, or even adulterating with additional mitragynine or 7-hydroxymitragynine that might be there to increase its potency. In 2018, and this was brought up by Dr. Volkow, was the FDA announced 44 deaths that they said were due to kratom. When you look at those cases, and I look at every overdose case of kratom that's published anywhere, all of but one contained other potent respiratory depressants, other prescription drugs, or other illegal drugs. All but one. And that one single case, when it was investigated, ended up being due to a motor vehicle fatality. Okay. But that publication by the FDA has really increased the number of medical examiners and coroners who will call a death a kratom related death. And we're going to talk more about that. And it has certainly was involved with the scheduling of kratom in a number of states, some of which have now, with more science available, reversed that prohibition of kratom, and others are looking at it. The next big event about kratom toxicity and overdose came out of the Centers for Disease Control. And this is a group that looked into the state unintentional drug overdose reporting system. And in 2016 to 17, certainly part of our terrible opioid epidemic that we are in the midst of, they looked at over 27,000 overdose deaths, and 152 of them, less than 0.6%, had kratom or mitragynine identified in the case, just identified in the case. And yet, medical examiners or coroners called almost 60% of these deaths due to kratom or mitragynine, a lot following the FDA guidance that it was a significant danger, public health threat. Of these, 80% were in individuals who were suffering substance use disorders. And in almost all the cases, they found multiple respiratory depressants, including fentanyl, which is so potent, an opioid, heroin, other benzodiazepines like diazepam and other benzos, prescription opioids, and cocaine. So they did, even the CDC found that most of these deaths were due to the presence of other substances, and in many cases, multiple substances. In 2019, Gershman et al. Looked at all Colorado deaths from 1999 to 2017, 19 years. And in that entire time, they found only 15 deaths that were listed due to kratom. In 11 of them, they found many, many different drugs that also contributed to the death. And they had a wide range of mitragynine concentrations. And also, currently, almost no one is measuring 7-hydroxymitragynine, the more potent metabolite. And we're going to have a lot of data that will help interpret those concentrations. And one of the most important things is that in the future, laboratories measure both mitragynine and its more potent metabolite. So there was blood remaining from, there were 4 deaths that did not have other drugs listed as potentially contributing, and there was blood left over from 3. There was one case where there was no additional blood. When the Gershman did a more comprehensive toxicology evaluation, they found multiple drugs in 3 of the cases where there was blood available. So again, the importance of comprehensive toxicology. Many of you, I know Kirsten asked, how many of you know about novel psychoactive substances? Aha, many fewer, but good. So what these are compounds where clandestine chemists go out and they add a molecule or two to well-known drugs, and they synthesize drugs that will be produce effects of cannabinoids or other stimulant drugs like amphetamines, etc. And they're completely synthetic, and we know very little about it. In fact, my last, I guess, 8 years at NIDA, I really focused on novel psychoactive substances, and we had an agreement with the DEA that when they found them and they appeared to be a problematic drug producing harm, we would figure out how it was metabolized because we didn't even know what these drugs were metabolized to. So most labs do not test for these novel psychoactive substances. In most cases, they have to go to reference labs that cost a lot of money. So when my investigation of these deaths, many times we found the presence of novel psychoactive substances that could be missed by medical examiner or coroner's laboratory. So again, comprehensive toxicology, very important. Now, another very interesting paper came out from the Florida medical examiners, and they looked at over 7,700 drug cases. They had many overdose deaths from fentanyl and other compounds. You can see that. And out of 7,700, only 106 had any measurable metragenine. But again, you can see, of course, when you find fentanyl, most medical examiners and coroners are going to list that as the cause of death. But with metragenine, even though it was present in a very small percentage of cases, 54% listed metragenine as the cause of death. And this is just not realistic or based on science. Dr. Henningfield talked about our studies in rats and other species and how little respiratory depression there is. So there is a very strong tendency to list metragenine as the cause of death, despite the presence of many other strong respiratory depressants. Now, if kratom is found along with other drugs, the appropriate way to do it is it's a polypharmacy death, and all of those drugs may have contributed. So there's absolutely nothing wrong with listing kratom as a potential contributor, but never to be listing it as the single cause of death when multiple other substances have been identified. Now, there were over 106,000 overdose deaths in 2021, about 75% due to opioid overdoses. And to our knowledge, none of these have been identified as kratom deaths. So when you hear that kratom is the cause of the opioid epidemic, there's just no basis for that at all. Many, as you've heard today from our speakers, are using kratom as a way of help self-managing their opioid use disorder or to prevent withdrawal, etc. as well. So again, when there are multiple drugs, all drugs should be listed as potentially contributed. We have a very important new paper that has come out recently, and it's from the individual scientists at National Medical Services, NMS labs, that does most of the metragenine testing in the United States. Most laboratories, local and state laboratories, don't measure metragenine. So what they have to do when they don't identify things or they find it in the home, it is frequently found in the home because the individual may have been using it to help with their opioid use disorder. So they send it out just for metragenine because they have to pay for it. And we have very underfunded state and local forensic toxicology laboratories. They can't afford to pay for test everything, look for the novel psychoactive substances, look for other fentanyl analogs, etc. So they send it just out for metragenine. They only find metragenine and it gets listed as cause of death. What's important in this paper is they compared all the concentrations. And I have looked at cases that they reported metragenine as the cause of death as low as 6 nanograms per mil. I mean, ridiculously low concentrations. So this paper has recommended you should not consider kratom as a cause of death unless the concentration is greater than 1,000 nanograms. Now, I want to point out, we do not know what the toxic concentration of metragenine is that could produce severe um, adverse events and death, possibly. We don't know that. And guess what? As researchers, we are never going to give people that much drug to produce those negative effects. The first issue of doing controlled studies is don't produce any harm. But we're gathering a lot more data. When we publish our data on controlled administration, we'll be able to say, well, here are concentrations where people were walking around, going to work, students, etc. So that will help too. But this is a good step in the right direction so that medical examiners and coroners, when they look at these cases and they find levels that are much lower, they won't consider calling that. So again, most labs don't do the testing in-house. It has to go out to an expensive lab. And therefore, we have many cases where that's all they looked for. And that's a real problem. Comprehensive testing is very essential. And so before it's called a kratom or metragenine death, they need to do a thorough scene investigation, always critically important, to look at what potential drugs may have been available. They need to expand their testing to look for other potential respiratory depressants that could be contributing. They need to look at all the circumstances of death, which may give them ideas. And they need to look at the decedent's past, determine were there substance use disorders? Were there other evidence of drug use that might guide them to what other drugs they should be looking for? Critical to quantify metragenine and 7-hydroxymetragenine, and then to be up to date on the literature where there's a lot of information now that we didn't have a few years ago about the lack of respiratory depression, about the other effects. So thank you very much, and we continue to work on this big problem.
Can you all hear me okay? I wanted to have when I found out I was going last, I wanted to have a different conversation with you all. And I knew that going last after this group would be incredibly hard to follow. And so I promise I will be really brief and I will get to that story. So when Congressman Salmon, when Ryan Burrows, the executive director of Kratom, asked me to talk about this issue, I said so under some very specific conditions. One was I'm used to being an attorney, and I'm not representing you. I'm not going to be your advocate and pound the table and say whatever the heck you want me to say. I'm going to tell the truth and tell my experiences. And so I know it's for that reason that they asked me to come and talk about my experiences, both as the US drug czar, but also my experiences with the FDA and in working with most of the folks on this panel. And I should say, I couldn't agree more with what Dr. Smith said. Please, please fully fund and exceed NIDA. Please, I beg you. But I also come today with a different experience and with a great deal of humility. I offer that I'm not testifying today or speaking today based on my experience at ONDCP alone. I'm also talking today as the parent of a child who is in recovery from a dependence to opioids. And by the grace of God, we're in our 7th year with our daughter. And we have a what appears to be on bended knee, a very happy outcome. And it's because of some wonderful treatment that they got. I see John Shinholzer here from one of the leading treatment centers in the country, based pretty close by, 2 hours away in Richmond, Virginia. There's some phenomenal treatment centers out there, and we're blessed to have been able to do that with our daughter. So I speak with humility for her. I speak also with humility on behalf of my best friend who lost his son 6 years ago today. So I looked at my phone real quick. I called him at 7:34 this morning to say, I know today's a tough day. I know it's the 6th anniversary of your son. So respectfully to the American Kratom Association, I'm not here to talk on your behalf. I'm here humbly to talk on behalf of family members and other people. About 20 million people, we think, in the US have an addiction of some sort. And so it's in that capacity that I speak with you. As talked about, we're losing 110 more or less, according to the CDC data, 110,000 people in the last 12 months. That's someone dying every 5 minutes. It's a major airliner going down every single day. 9/11 happening every 10 days. And so this is why there's so much need to look at this. I started my career as a drug prosecutor. I admit that now. You all can start throwing rotten tomatoes at me, right? Um, you learn pretty quickly when you first start as a prosecutor, you're like, I know the best treatment, it's jail. Um, that's the perfect solution. You quickly find out after about a week, it seems, that you started cycling people through and seeing them through, and you realize that didn't work. And so if we've learned and we've all grown and realized that addiction is not a criminal event, that we've stopped criminalizing addiction, why are we going to criminalize research? Why are we going to criminalize treatment when it shows great potential? And I think that's how we need to approach this issue, as not only as Congress, but also as families and as individuals, and stop the stigma, because I'm convinced that's part of what's going on here. It's a continuation of the stigma. And believe me, I felt that. I'm embarrassed to tell you that almost 7 years ago, we're in our 7th year, almost 7 years ago, when my wife called me and said, come home. And it was, oh my gosh, I can't tell anyone at work what's going on. It was when my daughter, she went to her boss at the time and said, I need to go into detox. As a parent, I don't know how parents in the room. One of the most terrifying things you can see is your child going through detox. And we only got to see her after 4 or 5 days. And it was still pretty bad. But she called me and it was like, and they said, look, you have to tell your boss you'll be gone for a while. And she told her boss, and her boss said, it was great guy. He said, look, we love you. You're doing a great job. Go get the help you need. Your job's going to be here. But do not tell the owner, do not tell the big boss, because you will get fired. And so my daughter did not go public with her story for a long time. And it was only when I was became the U.S. drug czar that we became more open and talking about it as she got more comfortable. And at that point, it was really too bad. She had left that position and gone to something else, because I was like, please go public and let them fire you. Please, for the love of God. Because what I wanted to do is to shame, and I hate to say that, but shame people for stigmatizing addiction and for not treating it the medical condition that we know it is. And so now I promise, Ryan, Congressman, I'll talk a little bit about my experience. And I oversaw the $35 billion with a staff of about 100 people at the White House to help people with addiction and the prevention. And so to talk about it, I make sure the executive director in the back of the room is not throwing arrows. What happened back on that event with the FDA has some wonderful people. There's talented, hardworking people. But they came to me as part of the convening process that I had at the White House to say, we need to criminalize Kratom. And I wasn't experienced with it. What they were saying made perfect sense. It was that, people were dying from it. And they presented their view. The next step in this was to get the DEA administrator, now a close friend and my business partner, and get him to sign off on it. And they were leaving me to go catch up with the DEA administrator when Brett Giroir, the Assistant Secretary for Health from Louisiana, don't know if we have any Louisiana folks in the room, called me and said, did the FDA come? He goes, yeah, they just came in and they are on their way to see the DEA. And he's like, where are they? And so thankfully at the White House, you can sort of find people. And we were able to find the DEA administrator, relay that to Dr. Giroir, who tracked the DEA administrator down at National Airport, stopped him from getting on a plane, and said, do not sign the order, that the FDA has not been able to tell you the whole story. And it was sort of the one-sided view that Marilyn talked about. And I'm not saying that the FDA is bad. It's that they only had one view. They only knew what they were being told. And I'm sure they will make available the letter from Brett Giroir that was referenced, to make sure that people understand that Brett Giroir, the Assistant Secretary for Health, who oversees the public health, oversees the U.S. Surgeon General, was livid about what the FDA presented that day, that it was only one side of it. So we did not have it signed. We made sure that it was withdrawn. And what we did really, as far as I am concerned, is took away the criminalization of research and the criminalization of treatment. If I can come to you today humbly on behalf of my daughter and her husband and my grandchild, I know that's kind of shocking. But as a grandfather, and I look at them today and I realize how incredibly blessed I am. How the treatment that Jack did many years ago on some of the MAT medication that my daughter used to maintain her sobriety at the beginning stages of coming out of detox meant that there were more lives saved. And that's what we're talking about today, is how are we going to save lives lost? Relapses today, we talked about fentanyl. I'm going to shut up after this one comment. Relapses today are different than the relapses that I experienced back in the 90s as a prosecutor, when you would see people, rotating through the courtroom where they relapsed and they were found, found to be using, found to be under the influence. You don't see that now with relapses like you used to, because as people recover, and relapse is part of recovery. For those of you who aren't familiar with it, that's a very common experience. But if you relapse these days, there's a tremendous increased chance that it's going to be a fatality. You don't know what you're taking. Your body that's not used to the incredibly powerful effects of fentanyl as you're becoming weaned off. And so I hope to be able to speak to you a little bit different. I didn't want to use slides. I thought about it. It's like, I'm going last. At first, I was going to put up a picture of my daughter. And I thought that would be my slide. Right, John? I mean, you? Um, the, um, but so today, that's what I'm here to talk about. And that's what I want to express to you all, is that desire to help these people that are suffering and be their advocate. So thank you. I sincerely appreciate this. Thank you.